So I wanted to welcome everybody. Thank you for coming to this session. Thanks to the Scleroderma Foundation for putting on another great program. I hope you guys are enjoying the program because I think it's been fantastic so far, and they've been doing a great job. And I'm really particularly happy about giving this particular presentation today because I think this is one that is incredibly important. And I want to start by saying that one of the best things I do as a physician taking care of scleroderma patients is meeting a new patient for the first time and having the opportunity to talk to them and tell them a little bit about the disease, probably many for the first time, hearing from somebody who has seen the disease, more than a handful of times, and just really giving them some education and the tools that they're going to need to take care of themselves going forward and to really advocate for themselves. And it's really the most rewarding part of my job. But I have to say the most important part of my job when I meet a patient for the first time is systematically walking through and thinking, okay, I need to think about kidneys and heart and lung and skin. And what the patient wants to know is, okay, I've read about scleroderma, I've seen things on the internet, you can read about all these things that can happen to somebody that has scleroderma. What they want to know is this going to happen to me? Is this part going to happen to me? Is this thing going to happen to me? And again, when I see a new patient, I systematically go through all these things, and what I want to give you is a little kind of behind the scenes about how we do that and how we think about each part of the disease and what we can tell when somebody walks in the door that might inform us with how things are going to progress in each of these areas going forward. So that's the goal for today. I'm going to start by talking about what's called phenotype. And that's a medical term that means what somebody's disease looks like. And there's a bunch of different ways we can make a phenotype, we can describe a phenotype, and we're going to talk about a few of them that we use in scleroderma. And then how we as physicians use that information about phenotype to inform progression. And I'm going to focus on some very key areas that, again, we think about in every patient systematically when they walk in the door with a new diagnosis of scleroderma, specifically the skin, lung, kidney problems, and pulmonary hypertension. I'm going to review some of the challenges in evaluation of therapy for some of these major manifestations of scleroderma and highlight how in many big centers like ours at Hopkins and many of the others of the speakers that you've been hearing from this weekend, how we, by systematically collecting data and understanding better this concept of phenotype and what that means about their disease going forward is really going to help us in the future really kind of crack the code and understand this disease better. So I know you guys can't read this slide, but this is a list of all the major manifestations of scleroderma outlined by Janet Pope in Canada. And with this, she said there's the rule of 15 in scleroderma. Many of the major manifestations of scleroderma, pulmonary hypertension, significant pulmonary fibrosis, renal crisis in those who have the diffuse form of scleroderma happen to about 15% of patients. So that's good to know and pretty reassuring. That means that obviously 85% of people don't have those things happen to them. But again, my job is to say, okay, well, who is that 15%? And what am I going to do differently in the patient who I think is going to be in that 15% than somebody who isn't? And I just wanted to make a brief mention about the word progression. Even though it's in the title of my talk, I don't like this term because it implies that everybody's on some natural trajectory to have X, Y, and Z happen to them. What I want people to think about is subgroups and this word phenotype, that things will happen to small percentages of patients who have scleroderma, but there's not some inevitable progression in everybody who has scleroderma. So again, this is our job, to figure out where you fit as a patient into this mix. So again, no uniform progression. Subsets of patients develop complications. And to understand one patient's individual trajectory, how they're going to do, is my goal when I'm taking care of a patient and they're in my office. Understanding the trajectories of groups of patients is incredibly important for us when we're trying to figure out if a drug works, which patients do we put into a clinical trial, which drugs should we use for which patients. That's important for us in the research community. But when I'm seeing a patient one-on-one, I want to know that patient's individual trajectory. So I'm going to start by presenting a case. So this is a patient, 45 years old, who was well until June of last year. At that time, she developed new onset of hand stiffness and swelling, and then she began to develop cold sensitivity and Raynaud phenomenon, and then abrupt swelling in her hands and feet. And then by the end of that year, finger ulcers and tightness in the skin. So this scenario may sound very familiar to some of you because this is a very typical presentation of somebody with early diffuse form of scleroderma. She was seen by her PCP in October and thought she had an arthritis of some sort and carpal tunnel syndrome, referred to rheumatology and seen in December. As is very typical, these autoimmune rheumatic diseases may look very similar at the beginning. So early scleroderma may resemble rheumatoid arthritis, may resemble early lupus. So that was the differential diagnosis of the rheumatologist at the time. And they did some basic laboratory evaluations, which did suggest that the patient is in the connective tissue disease family because they have this ANA test. But they didn't find any of the other specific antibodies that may point somebody into the direction of scleroderma or lupus. And they had some elevation of these markers of inflammation in their blood. And again, the rheumatologist said, you're in the connective tissue disease family, maybe this is early scleroderma, and refers to a scleroderma center. So when I see the patient in early 2014, what do I appreciate? I see that there's skin tightness in fingers, hands, forearms, feet, and I do this modified Rodnan skin score, which you've heard about multiple times, where we're assessing the skin in 17 different areas in the body and deciding how much tightness there is. I noticed these things, tendon friction rubs. So this is the tendons moving through this extra collagen, making this painful, but also palpable. I can feel it, rubbing sensation. I noticed that the blood vessels in the tips of the fingers are abnormal, and do an additional test that hadn't been done before to look for this antibody RNA Polymerase III, and found that to be positive. Fortunately, heart and lung tests were normal. So now I have this patient in my office. They're newly diagnosed with scleroderma. What they want to know is, what can you tell me about what's going to happen next? My skin, my lung, am I going to have other problems? And if so, what therapy do you have to offer me? Now, I'm not going to focus too much on therapy because you've had lots of other talks talking about treatments, including Dr. First right before here talking about some new treatments. But I want to say something about how we decide who we're going to treat for what complication. All right, so I used this word phenotype before. Phenotype just means an observable characteristic. And in scleroderma, phenotype could either mean the type of skin disease that you have, either the milder skin version, the limited form, or the more diffuse skin form where there's more widespread tightness in the skin. How much organ dysfunction there is, like lung fibrosis. Is there a little bit of lung fibrosis, a lot of lung fibrosis? Antibody type, I mentioned this patient that we're talking about had antibody to RNA Polymerase III. You could subdivide people with scleroderma into the antibody type that they make, and that may tell you something about their disease. And if you can do this sufficiently and say, okay, this person has this and this and this, then what's important with big centers like ours is that we can say, okay, put that information in our database and then look and see what happens over time. And many centers have done this over years now, and this is how we know a lot about these different subsets and what might happen later. So then the next step is going to be you combine that phenotype and what you know about that patient with biomarkers or gene signatures like you've heard about, and then you really can take things to the next level and be able to even much better predict what's going to happen to an individual patient more than we can now. So I mentioned one of the ways that we might phenotype a patient is by their autoantibody. And lots of studies now have accumulated from larger scleroderma centers, and they tell us something about the type of disease that they might have. Where the patient who makes the centromere antibody more often has this crest type of scleroderma, very mild skin disease, whereas somebody who makes topoisomerase I or the SCL70 antibody has a much higher risk of having lung fibrosis, and so on. So this is one thing that we need to know when we first see somebody. Do they make one of these very characteristic scleroderma antibodies? And that may tell us something. And I'll go into more detail as we get into each of the different features of the disease. So after I assess somebody, I take all these different things where we could phenotype based on extent of skin, how early they are, what type of antibody, and you could imagine there can be tons of different combinations of all of these things. They could be earlier in scleroderma, they could have the limited skin disease, they could have a little bit of lung fibrosis or a lot of lung fibrosis, they could have bad Raynaud's or not so bad Raynaud's. And again, the important thing from a research standpoint is to take all this information and say, okay, if somebody comes in and has X, Y, and Z, and we follow them over time, what seems to happen to that group of patients? Okay, so the patient I presented, kind of what conclusion could I come after that first visit in terms of the type of scleroderma that that patient has? Well, I would describe that patient as having early disease. Her symptoms had started in the past year. They have, based on the areas of skin that were involved, they have the diffuse phenotype, subtype. They make that RNA Polymerase III antibody. They had these tendon friction rubs. Their first set of heart and lung data were normal, and they had had digital ulcers. That's the kind of the crux of what their presentation is about. And these are the things that I'm going to take now and say, okay, what does that mean about their kidney, their lung, their skin? So let's talk about skin first. So as you know, we assess the skin in research and for clinical trials by doing what's called a modified Rodnan skin score. So this is me pinching all these 17 different areas in the body and giving it a score between 0 and 3, 0 meaning not affected at all, and 3 being very tight. And this provides an overall score of 0 to 51. And we could spend a whole other talk talking about the pros and cons of the skin score and what its limitations are, and I think I actually have a slide in your handout about some of the limitations. But this is really how we've assessed the skin over time, and this type of data followed over time is how we know much about what happens to the skin in scleroderma. You hear a lot of talk about the natural history of skin disease and how overall the skin in people who have diffuse scleroderma does seem to get better over time. So this is one such example. This comes out of the UK group, Chris Denton's group. This was not untreated patients, but these were patients getting a variety of treatments. And their skin score started out at a level of around 30 on average, and gradually over the next 5 years, gradually improved. Again, these patients weren't untreated. Most of the data that we have right now, we're not so sure how much of an impact treatment makes, but this just gives you a sense of what happens naturally in the subgroup of patients who have diffuse disease. So then they took that information and said, well, are there different groups of people? Are there different patterns of what happens to the skin score over the first few years of disease? So this took groups of patients and subdivided them into people who started high and didn't really seem to get much better over the first 3 years. Then this group that started high but seemed to improve, and this group that started low but also lower but also seemed to improve. And they say, okay, let's look at their other characteristics that they presented with their scleroderma and say, can we say anything that predicts kind of which group this patient's going to be in? And I know this is hard to read, but what this shows is that people who were, what we really want to know is, can we differentiate this person who's starts high and is not going to improve from the other groups who are going to improve? Because maybe if naturally that's what's going to happen, you would maybe even be more aggressive with that group who otherwise hasn't seemed to have responded to normal treatment. And what we can say is that age and the duration of disease someone has when they first present, meaning from symptoms until we first started measuring their skin, are really important probably in figuring out kind of which of these trajectories someone's going to be in. People who were high at the start and didn't seem to improve were a little bit older when they developed scleroderma and had a little bit longer disease duration, which is part of the reason why when we design clinical trials for skin disease, we're trying to pick the people who are in the very earliest stages of disease because we think maybe they're going to be responding better, that maybe our chance to impact response is going to be better. So this tells us a little bit. But if you look at the ages on here, 43 versus 45, that's not going to help me so much with an individual patient. So what else do we have? Now, this doesn't come from real data. This is kind of my gestalt about some of these antibodies and how that impacts the skin score. And I think those of us who see a lot of scleroderma have this innate sense about what's going to happen to somebody who has a very particular antibody type. The people who make RNA Polymerase III Antibodies, so that's the top line here, on average have the most aggressive type of skin disease, meaning that it progresses the fastest in the first couple of years. They also, though, when they tend to get better, tend to get significantly better. People who make some of the other antibodies, like the centromere antibody, I told you that associates with a limited skin disease. Their skin is mild to begin with and is going to stay mild forever. And so we don't think about using immune-suppressing medicines to treat the skin in people who have that subtype, at least for their skin part of the disease, because there's really not much improvement to be had. Their skin disease tends to stay mild. And the people who make some of the other antibodies tend, on average, to be somewhere in the middle. This slide shows some of the trajectories and some of the clinical trials that have been done in scleroderma, again, showing this sense that over time, even in people who are on a clinical trial, that the overall tendency is for gradual improvement. But this data comes from our retrospective looks. We went back and looked at our patients who were getting CellCept. So this is a drug you've heard about for a while. So we went back and looked at about 100 patients who had received CellCept in our center for their skin disease. And I know this is a complicated slide, but this is groups of patients divided by when they first came into the clinic and how long they'd had disease. And then this is looking what happens to their skin score over time. And I just want to show you again that this may mean that duration makes a difference, that if we started somebody who was earlier in the disease course on their drug, I think you can imagine that this trajectory looks a little different than maybe some of the other ones. So again, just suggesting that duration makes a difference, we think. So let's go back to our patient and think about their skin. So this patient was early and made this RNA Polymerase III antibody. And again, I showed you that is the group that has the most rapid progression in terms of skin disease. And again, she was early. So therefore, I would say that I'd be worried that this person is at high risk for progressing in terms of their skin. And we would probably, all other things being equal, and with normal lung tests, we would focus treatment on their skin and improving the progression. And this person would also be a very good candidate for trials in scleroderma for skin disease. What does that mean? Again, features at presentation may tell us a lot about how the skin may change over time. The overall tendency in the skin is for improvement, which is great to hear. Makes it harder for us to assess drugs. When we know the natural history is that things are going to get better, our drug has to outperform that natural history. And so clinical trials really need to harness this phenotype data to say, well, what is the natural tendency for this person to progress? That way I can weigh my drug against what this natural tendency should be. And this, for us, again, from the research standpoint, is where we have to balance the ideal. If it were ideal, I would pick this group of patients that I could say I know exactly what's going to happen to their skin, be untreated, and then compare my drug against that. But that means narrowing the group of patients who are available for clinical trial to this very specific small group of patients versus feasibility. We need to have enough patients to know if a drug is going to work. And that means that we have to examine prior, quote-unquote, failed clinical trials where we weren't taking into account so much of these things years ago, that we need to approach them with a little skepticism. It means maybe if we had subsetted patients better or chosen patients differently, that some of these trials may not have been failed. I think a home run drug is going to negate all of that. If you're trying to determine is something different than this kind of overall downward trajectory, and somebody goes like this on a drug, straight down, their skin score gets dramatically better in 3 months' time, these things aren't going to matter so much. Hopefully we're going to get there with a drug like that, but until then we have to take all these other things into account. So I'm going to change focus now and talk about scleroderma lung disease and specifically about fibrosis or scarring in the lung. What we know about the epidemiology in terms of who's going to get interstitial lung disease, we know that most patients with scleroderma have some degree of fibrosis in their lungs, most. But a small minority of patients in that group are going to have more fibrosis happen over time. And depending on how you define fibrosis, by CAT scan, which is more sensitive, or breathing test, which is more sensitive, we'll pick up this fibrosis. But again, this group of 15, again, going back to the kind of rule of 15 in scleroderma, about 15% of patients are going to progress. And we know that lung disease is one of the major problems and complications in scleroderma we face today. So what do we know about who's more likely to be in this group of 15%? So patients who have the diffuse cutaneous, diffuse skin form of the disease are more likely to have concomitant lung fibrosis. In terms of those important autoantibodies that I talked about, we know that this topoisomerase, or the SCL70 antibody, correlates most strongly with progression of lung fibrosis. Again, people who are early in disease, you've heard this a few times, most of the decline in lung function happens in the first several years of disease. Your racial and ethnic background makes a difference, so patients who are of African descent have a higher risk of having progression in their lung. And if your baseline testing in terms of pulmonary function testing, CAT scans, are already abnormal from the time somebody figures out that you have scleroderma, you're more likely to be in that group. In terms of things we consider to be negative predictors, so the two other autoantibodies, the two other major scleroderma autoantibodies, centromere and RNA Polymerase III, they're actually less likely to progress overall in scleroderma in terms of the lung. And if you have normal function of the lung or CAT scan at baseline, you're less likely to progress. So where do we have additional data about who's going to have worsening lung function over time? Well, most of that data comes from Scleroderma Lung Study 2. For those of you who don't know, this was a study that was done that looked at Cytoxan to treat lung disease in scleroderma. And this was comparing to placebo. So half the patients in the study got Cytoxan, half of the patients got placebo, and it was done over 5 years in 13 centers in the United States and included 158 patients. So this was the overall, what we call treatment effect. So people who were on Cytoxan had an overall 2% difference in their lung function at 12 months than people who were on placebo, which doesn't look like a huge difference, but it was what we call statistically significant. And to go along with that, thinking that this was telling us that the drug probably is doing something, is that patients who were treated with Cytoxan felt better. These positive scores are improvements in breathing scores over the course of the study. So it's not just that we saw this small improvement in lung function, which is important. Patients also felt better who were on this drug. So what can we learn about the progression of lung from this study? So this slide's a little hard to follow at first. Each of these bars and these numbers here represent numbers of patients. And these are the numbers of patients who got Cytoxan, and these are the patients who got placebo. And above this line are people who had improvement in their lung function, and below this line are people who had decline in lung function. And as you can see, overall, more people who got Cytoxan had some improvement or stabilization in their lung function, and more people who got placebo had some decline or worsening in lung function. But there were a lot of people here who hung out in the middle who really didn't have much change, including in the placebo group. So there's a lot of people who didn't have a lot of change in their lung function, which means probably we had put patients in this study who naturally weren't going to progress, which made it a little harder to tell the difference between Cytoxan and the placebo group. So a couple things were done after this study. So that was the main results of the study, and this was a very important study in the world of scleroderma, basically the first positive clinical trial we'd had for a drug in scleroderma. But they did a couple things after the fact, and they did what's called a responder analysis. So they looked at the people who improved the most on Cytoxan and said, well, what about the characteristics of those patients? What do they look like? And actually, this is probably different than any of us would have expected. We would have thought if we'd gotten the patient who had the earliest lung function decline and had the mildest disease and prevented them from getting worse, that would be the group. And it turned out to be the opposite. So the patients who had the lowest lung function to start with had the most benefit from the cyclophosphamide therapy. And that was measured by both CT scanning and by lung function tests. So the people who had the most benefit were those who had more disease. And that probably means that the people who had milder disease probably naturally were not going to progress. So we've picked out this group who likely is on a trajectory where in the absence of therapy, they were really going to keep going down. And that's why we could see that difference, bigger difference between the placebo group and the Cytoxan group. Disease duration in this study did not make so much of a difference, which is important again when we're talking about designing a clinical trial for the lung, that we usually think of adding just early patients, and maybe that didn't make so much of a difference. So this data comes from the placebo arm of this trial, where they just looked at patients who got the sugar pill and said, well, let's look at what happens to their lung function over time, and again, see if we could predict how we can figure out who's going to be in the group, who's going to decline. Disease duration in this study did not make that much of a difference. Again, what did make a difference is how much fibrosis they had on their CAT scan. So people who had more fibrosis on their CAT scan, more scar tissue in their lung at the beginning of the study, were going to be on a trajectory where untreated, again, this is the placebo arm patients of this study, were going to continue to lose function over time. So this really was important for us to know because, again, it probably was opposite of what we had probably thought going into the study. Well, if we could get that early patient with the very mildest disease, we're going to have the most impact. And actually, the most impact was felt in people who was seen in people who had more fibrosis in their lungs and lower lung function to begin with. And so now that's gotten us to a place where we could have a relatively simple algorithm for scoring somebody's risk for progression. And this is a combination of what we see on the CAT scan and what we see on the lung function test. And we can use this, and again, people who we would now place into this what's called extensive disease group, that's the group we should probably be targeting with drugs for lung fibrosis and scleroderma. In addition, these trials have done another important thing. I talked before about biomarkers. They looked at blood biomarkers, things that we can measure in the blood and say, does this associate with who's going to progress in terms of lung function, or does this associate with who's going to improve on a drug or not? And so this is still relatively young in terms of development, but there are some candidate biomarkers which may be helpful to, again, help us predict the natural trajectory of what's going to happen to somebody's lung over time, and that's going to help us do these studies better in the future. All right, so let's go back to our patient. Again, so in terms of the phenotype, they were early, they were diffuse, but they made RNA Polymerase III Antibodies, and they had normal lung function tests at baseline. So if this patient was in my clinic, I would say, you know what, because of the Polymerase III antibody, because of your normal lung function tests at baseline, we don't need to really worry so much about progressive lung fibrosis in you. Yes, we're going to watch it because we watch it in everybody, and we're going to make sure you at least once a year get your PFT test done. But we don't have to worry so much right now about this in you. We're going to focus on your skin and maybe some other manifestations of the disease, which we'll talk about. So again, to conclude about the lung, Cytoxan had a significant but modest effect on lung function at 12 and 24 months. Fibrosis, extent of fibrosis seems to predict decline and influence treatment effect, and disease duration in this scenario didn't make as much of an impact as it does probably for the skin disease. Selection of less severe and less likely to progress of patients in the clinical trials may have underestimated the treatment effect of Cytoxan, and in the future, clinical trials are going to take this information into account when we're deciding to do a new study for lung disease and scleroderma. The next problem I'm going to talk about is scleroderma kidney disease. This overall is the least common, but one of the most serious complications we face in scleroderma. This used to be universally fatal. Before we realized that ACE inhibitors were effective to treat this, people who developed scleroderma renal disease universally died from complications of this. And this was the leading cause of mortality back several decades. This has improved dramatically now. The majority of patients not only survive renal crisis, but they survive without having to have gone on dialysis. And we know a little bit about, once somebody has renal crisis, some of the factors that may predict, how well their kidneys are going to recover. But really, how we treat this is not the big issue with scleroderma kidney disease. It's making sure we pick it up early. And so people who present with worse renal function, when they get recognized as having renal crisis and start getting treated, do worse. So this is an important area where picking it up early makes the biggest difference. So this is a huge educational thing for me in clinic when I see a new patient. Do I think this person is at high risk for developing renal crisis? Let's make a plan to figure it out. So the risk factors for development of this are diffuse skin disease with rapid progression, people who are early in scleroderma, patients who are African descent, people who make that RNA Polymerase III antibody, their risk is about 25 to 30% of people who make that antibody will have this kidney complication, as opposed to 3% in the overall scleroderma population, so that's a huge difference. And those who've been exposed to prednisone or other steroids at moderate to high doses seem to be at higher risk. Surprisingly, things that have nothing to do with predicting whether somebody's going to develop kidney disease or not is what their blood pressure is at baseline, what their kidney function is at baseline, what their urine looks like at baseline, none of those things. So we don't, besides what somebody looks like, besides their phenotype and their antibody, we don't have a lot of other things that are going to tell us who's going to be that person. So again, this RNA Polymerase III antibodies, this is about 5 to 18% of people who have scleroderma. I already mentioned that they have the typically most aggressive type of skin disease, and 15% of patients will have their skin disease precede their Raynaud's, whereas in most other patients, Raynaud's precedes their skin disease, and have the highest risk for renal crisis, and I already mentioned have low risk for interstitial lung disease. Okay, back to our patient. Rapid skin disease progression, early disease, and RNA Polymerase III antibody. This is the person who is in my clinic that we have a 10-minute conversation about how we're going to watch for their kidneys. So that means education is key, because it has happened in the past where if I don't tell the patient what to do when they have this scleroderma renal crisis happen and they go to an emergency room or their primary care doctor, it gets missed. And if this is allowed to go untreated, that's when there's damage to the kidney. So educating the patient about this is crucial. That means they have to watch for the very first signs of scleroderma kidney disease, and that's blood pressure elevation in the vast majority of patients. And this doesn't mean, I go to my doctor even once a month and they check my blood pressure and it's fine. You need to know what your blood pressure is several times per week, because if the scleroderma kidney disease goes unchecked for even a week or two, it could have already done significant damage to the kidney. So I tell my patients, they walk out the door with a prescription for a blood pressure cuff, make sure they know how to use it, make sure it gets calibrated in their doctor's office to make sure it's accurate, and they're doing that 3 times a week at least if they're in this group that has this RNA Polymerase III antibody. And then I say, and here's the plan for what to do in all scenarios if you get blood pressure X. Here's who you call, here's what you say, here's the next steps. So screening is the best mechanism for prevention of kidney damage and scleroderma, and early detection clearly improves outcomes. We won't go into it, but there's no data that pre-treating with the drugs that we use to treat scleroderma kidney disease prevents it from occurring. In fact, the data suggests maybe people who are pre-treated even do worse. So we don't give people the drugs in advance, even if they're in a high-risk category. And education of patients and physicians is vital for this. So the last major area I'm going to talk about is pulmonary arterial hypertension. And this is a little different than some of the areas we're talking about, because this is typically a later manifestation of scleroderma. This occurs 7 to 10 years after somebody develops scleroderma. And so our plan for this is usually kind of the long-term plan for how we're going to follow this. So just a word about what pulmonary hypertension is, because as much as we'd like to simplify it and say this is one thing, it's probably more than one thing. So most of the time we are thinking about this, what's called pulmonary arterial hypertension. So this is involvement of the arterial side of the connection between the heart and the lung. And that's what the drugs are approved to treat, this PAH. Some of our patients have lung disease, which interferes with the exchange of oxygen between, again, the heart and the lungs, and that can lead to some forms of pulmonary hypertension. And some patients have some stiffness in the left side of their heart, which may or may not be related to scleroderma, but can cause a different type of pulmonary hypertension. Most of the time, though, we are talking about screening for this pulmonary arterial hypertension, which we associate with scleroderma. And if we just step back and think about when pulmonary hypertension develops and what's happening, if you take the onset of vascular disease from the onset of Raynaud's phenomenon, that's when something starts happening to blood vessels, when Raynaud's happens. We diagnose diffuse scleroderma usually pretty soon after that happens because they get lots of other things that are happening to their skin, to their GI tract, other things. And patients who have limited scleroderma tend to gradually accumulate some of these other things over time, and then we ultimately make the diagnosis of scleroderma. And probably some of the reason why we think of pulmonary hypertension occurring more often in those with limited scleroderma is that this and when somebody develops pulmonary hypertension are much closer together. But we really think of the whole group as being at risk for pulmonary hypertension, but again, the risk seems to go up later in the disease. We know that if you have pulmonary hypertension, things are worse in terms of survival. This is older data versus newer data. But newer data in scleroderma pulmonary hypertension is relative too, because this is something that is changing on a month-by-month basis, with new drugs having come out in the past few months to treat this. So we think this is continuing to improve over time, but we just need enough time with the new drugs to know that we're making this impact. What we do know, though, from some early data, and this is data out of France, that put patients on a very strict screening protocol for pulmonary hypertension versus standard of care. And then if you take those two groups of patients and you take the ones who are on a strict screening protocol versus standard of care, and from the time those groups of patients developed pulmonary hypertension, and then you followed how well they did, the people who were in this more intensive screening protocol did better. So this is another area in scleroderma where we need to pick up the patients early who we think are on a trajectory to develop pulmonary hypertension, because we think treating them earlier is going to make a difference. So what are some of these risk factors? Again, this isn't something we're thinking about at the first visit in terms of, are we worried that somebody has pulmonary hypertension right now? It's how do we make a plan to keep following this over time? So risk factors that at baseline, so the age at which somebody develops scleroderma seems to be a risk factor, and if you develop scleroderma in your 60s or 70s versus your 40s or 50s, we think the risk is higher. Again, this is a little bit biased, this limited scleroderma, because they more often developed that isolated pulmonary arterial hypertension, but all patients with scleroderma are really at risk for developing this. People who have severe other vascular problems like Raynaud's phenomenon may have this more. And there are things that we can measure, and we do measure routinely, that if abnormal, predict who may be developing pulmonary hypertension. And there are some antibody associations, but they're not quite as robust as some of the other antibody associations that I told you about, and include antibodies that we don't often routinely test because there aren't really commercially available tests for these for the most part. So the antibody is not as much helpful in pulmonary hypertension. But what we do know is that there are signs that pulmonary hypertension is developing years before somebody has overt pulmonary hypertension. So the most important of which is the DLCO part of the pulmonary function test. That DLCO part of the pulmonary function test measures how well oxygen is getting across. And in a study done by Dr. Steen from the data from Pittsburgh suggests that 5 years before somebody had developed obvious pulmonary hypertension, their DLCO test was abnormal. So even in patients where we are not worried about the fibrosis part of their disease, in those first few years, we keep checking this PFT every year so we can watch the trajectory of what's happening to this DLCO over time. I'm sorry, it says, this just said that the patients 4.5 years before they were diagnosed with pulmonary hypertension had a DLCO of 52% of what it should have been. So it was actually significantly low. It should be between 80 and 100%, and 5 years before patients were diagnosed with pulmonary hypertension, it was 50%. We did a study at Hopkins because we had appreciated that patients who had pulmonary hypertension tended to have more of these telangiectasias, these dilated blood vessels. And this turns out to be true when we systematically looked at this, that patients who had larger numbers of telangiectasias, these dilated blood vessels that occur in different places, had a higher risk for pulmonary hypertension. And as I'd mentioned, this is another study that came out of our group that looked at patients who developed scleroderma older than 65 or younger than 65. And this is the number of patients who develop pulmonary hypertension in the younger group versus the older group. And this suggested that patients who develop scleroderma at an older age may be at higher risk for that. So as I mentioned, this is an area, because it's something that we think is developing, maybe even years before somebody really has symptoms from pulmonary hypertension. This is another fantastic area for biomarker development. If we could find something in the blood that tells us these little blood vessels in the lungs are being damaged, that is ultimately going to lead to pulmonary hypertension, this is going to give us much better prediction. And again, because we have early data that suggests that treating earlier may make a difference, then we think we'll ultimately really improve how well somebody does. Now that we have drugs, 9 drugs in the United States now to treat pulmonary arterial hypertension, that this is going to make a significant impact over time. So let's go back to our patient. So again, their phenotype again was that they developed scleroderma early and at a younger age. They didn't have telangiectasias, and again, their screening studies at baseline, including PFT and echo, were normal. So in terms of treatment, we're not talking about treatment. We're not talking about being worried that they have pulmonary hypertension now or probably in the next several years, but they go on an annual monitoring plan to look for signs of pulmonary hypertension, most importantly PFT and echo, but hopefully these biomarkers will start to be incorporated into this, and we can even get better at predicting when this is developing and catch it early. So those are the 4 areas I wanted to talk about. So to conclude, all scleroderma is not the same. I know you hear that over and over again, that every patient with scleroderma is different, but actually we can harness understanding those differences to understand the disease better. And progression is not uniform and definite for any of these things. The 15% rule for major complications helps, but knowing who that 15% is the key. Large data sets have provided really all this information comes from these big prospective registries, so your help in doing this research is vital for us to understand this better. And we are so grateful to all of our patients who come to our center and other centers who agree to participate in research and allow us to put information about their scleroderma into our database. This really empowers physicians to better manage scleroderma patients, understanding these differences and nuances. And now clinical trials can and should integrate these phenotype data into selection and design of clinical trials going forward. And as we understand the biology better, we're going to get better at this biomarker development. And this has been incorporated already into clinical trials. And every time we do a clinical trial, we're going to learn more about these biomarkers and their ability to better predict when these things are going to happen in scleroderma. And these things need to keep going. So I'm going to stop there. And I think we have about 10 minutes for questions, so I'd be happy to take those. Thank you very much. So the question is, does the severity of Raynaud's tell you something about what's going to happen in blood vessels and other places? We do have those epidemiologic connections, again, like pulmonary hypertension would be the example, where patients who have had digital ulcers more often develop pulmonary hypertension. It's a relative thing, so it's not an inevitable thing, but it does get into the mix of things that we say, let's look at somebody's risk factors, because the vascular things in general do tend to go together. That is true. Yes, right behind you. Mm-hmm. Mm-hmm. Yes. So we know much less because the question was, what do we know about juvenile onset systemic sclerosis and some of these progression factors, and about exercise-induced pulmonary hypertension, and what does that tell us about pulmonary hypertension? So unfortunately, we know much less about juvenile onset systemic sclerosis in terms of these risk factors. We can assume that some of them may be similar, like the autoantibodies may be similar between adults and children in terms of risk for progression, but it hasn't been studied that well just because it's much less frequent in children to have the systemic onset of a systemic form of the disease. But what we do know about exercise-induced pulmonary hypertension, the pulmonary hypertension world has gone back and forth on this. And we think that people who only have their pressures elevated at exercise probably are at higher risk for developing rest pulmonary hypertension. The data is a little bit limited, but suggests that. So that's a group we would watch much more closely in terms of developing pulmonary hypertension. What we don't know yet is, and what we would love to know, is taking that patient who has exercise-induced pulmonary hypertension only or has borderline pressures. We make the diagnosis at 25, and the person who has 23 and 24, who we also think are at risk for progression to PH, if treating that person is going to, even if they don't have symptoms, is going to keep them from progressing. We'd love to have that data. We don't have it yet, but it's going to be coming. Yes? Having your what? I'm sorry. The question is there any point in having your exome sequenced now in terms of predicting progression? We're just at the tip of trying to understand. We're actually doing a study coordinated out of our center with whole exome sequencing in African American patients with scleroderma to see if we can discern anything about it, but not yet. In research arenas, yes, we think it's at least going to tell us something, but not yet in terms of predicting progression. Yes? Uh-huh. Yes. So the question is, when does scleroderma develop? Is it when Raynaud's starts? Is it when somebody sees lung problems? Or is it when somebody puts it all together, or you have trouble with the skin tightness in your hands? And I'll have to say this is an area amongst scleroderma experts we disagree on. Because there are some people, so the risks of starting it at Raynaud's are that there are some people, so 10% of young healthy women have Raynaud's, and by chance alone, some of those patients are going to develop scleroderma later. So they really had primary Raynaud's, and then they really later develop scleroderma, and maybe their Raynaud's gets worse at that point. If we say their scleroderma started then, we might be skewing things. However, there's other people who have Raynaud's happen later or don't have Raynaud's at all, so we try to time the disease to when other things start. And the important thing from a research standpoint is to make sure when we do that, we do it systematically. We pick one way and we do it, or we actually analyze things a couple different ways, either from when Raynaud's started or from other symptoms starting. But the answer is in an individual patient, particularly somebody who developed Raynaud's in their teens, where it could still be primary Raynaud's and more likely was Raynaud's, we would typically start from the first non-Raynaud's symptom, which we can directly attribute to scleroderma. But it's complicated in you because of the lung problem. And so we'd have to know kind of really what that lung problem was to really know. Yeah. So, yes. Yeah. The answer is so the question is, what's the appropriate drug for somebody who has exercise-induced pulmonary hypertension only? And the answer is we don't know, but some people believe strongly that that's a big enough risk factor for developing what we would consider to be, rest PAH. If in a symptomatic patient, that it might make sense to treat that patient, but we don't have any studies that tell us one drug versus the other. We don't even have very much of that head-to-head drug treatment for people who have kind of normal established PAH. So I think it's reasonable to try, particularly if somebody has symptoms, but we don't know yet which drug is the right drug, unfortunately. These groups are going to start to be studied more often. So yes, Gray.
You said to check your blood pressure regularly, but some medications like amlodipine and some medications take Renal to drop your blood pressure. So, and then some of us are on blood pressure medicine because our blood pressure is high. So
Right.
how do you know if you are having a blood pressure emergency?
Yes. So the question is if you are on blood pressure medicines already, or if you have baseline run-of-the-mill high blood pressure to start with, how do we look for scleroderma kidney disease in that group? So it does get a little trickier, and if somebody comes in and their blood pressure is a little bit high, do we get nervous? Yes, I get nervous sometimes when patients come in like that. So the important thing is to know what your blood pressure is normally. So everybody's going to have a little range of blood pressures that's their baseline blood pressure. And for people who have baseline hypertension, we're trying to pick up some sudden change in their blood pressure. So on average, we're talking about, maybe a 20-point change. So you run 125, 132, kind of in that range, you bounce up and down. All of a sudden now you're 150. That's what we want to know about.
And like now I'm on medication for Renal, and now my blood pressure is really low.
Yes.
So how do you know if that's artificially keeping it low when you might be having a renal?
Right, so there are some patients who have what's called normotensive renal crisis. Those are very uncommon and a little harder to predict. But if people are on a calcium channel blocker for Raynaud's phenomenon to help with their blood flow, that drug doesn't do anything to prevent or treat scleroderma kidney disease. The expectation would be your blood pressure will still go up significantly even though you're on those medications. So you'll still be able to pick up that change in blood pressure. We don't think it masks it. Now the question is whether the ACE inhibitor drugs are masking the renal crisis, and that's why we're pre-treating with these drugs. Patients don't do as well because we're missing that kind of sudden surge in blood pressure, and that's one of the leading theories why those studies have suggested that pre-treating with those ACE inhibitor drugs actually causes patients to do worse, but we're still trying to understand that better. Take it regular and know what your baseline is and what your range is. 5 minutes, okay. Yes?
If you are already on ACE inhibitors, should you come off the ACE inhibitors? Because to me it's like a damned if you don't, damned if you do situation, but then what if you decide you're not going to take it? Do you now go back to damned if you don't?
Yes. So the question is, what if you're already on an ACE inhibitor? Should you stop it? And it really comes down to why did they put you on the ACE inhibitor to begin with? So in my practice, if somebody has come in and I'm seeing them as a new patient and they were put on an ACE inhibitor purely to prevent renal crisis, not because their blood pressure was high, they're not using it for some other reason totally unrelated to their scleroderma, I tend to stop it. Why? Because I'm in the camp that believes that that ACE inhibitor may mask this boom increase in blood pressure. That's the signal that something is going on in the kidney. And again, that's one of the theories why the studies have suggested that maybe patients who are pre-treated with renal crisis may do worse. We don't know that for sure, but that's my practice. I think we probably have time for 1 or 2 more questions. Yes, right here. I'm sorry.
And now this one's doing the same type of thing. I don't know what I'm trying to ask. I don't want to lose another finger up.
Yeah. So I wish I had time to put a section on digital ulcers in this talk about how to predict who's going to develop digital ulcers. We know that 50% of people with scleroderma will develop digital ulcers, and those people who have had ulcers are at higher risk from having them happen again. But keep in mind that there are 2 types of ulcers. There are the ones that happen on the tips of the fingers, which we think are purely ischemic, meaning it's purely a matter of decrease in blood flow related to the Raynaud's and the blood vessel problems. And then there are these ones that happen over the knuckles in people who have contracted fingers because the skin is tight, like your hands, the skin is tight and it's dry and it has relatively low blood flow and it's prone to getting traumatized because they get bumped just because we use our hands. And we think of those a little bit differently than the ones that are purely blood flow issues. Yeah. So the problem with people who have low blood pressure and who have Raynaud's and ulcers is complicated because almost all of the medicines that we have to treat Raynaud's and digital ulcers all lower blood pressure. The exception being Prozac, and we think it's probably all of that SSRI class of antidepressants. The impact it has on serotonin and the role that plays in Raynaud's probably makes sense, and there's one clinical trial of Prozac suggesting that it helps Raynaud's. So that's a drug I will often turn to in people who have very low blood pressure at baseline who cannot tolerate any of the other vasodilator medications. Yeah, so we don't know that, we assume that that effect of the SSRI medicines is a class effect, that it's not just Prozac. There's probably not something magical about that one in particular. It probably is the whole group of those drugs. So I think it's a very reasonable thing to consider. All right, I think, last question, right? Mm-hmm. Yeah, so the question is about the calcium channel blocker amlodipine and those with low blood pressure. I personally find that I can get almost anybody, even somebody who comes in with a blood pressure of 90s over 60s, to tolerate a very low dose of that calcium channel blocker, even though those medicines do lower blood pressure. The question is that tiny dose going to measurably impact your Raynaud's? And that's where it's maybe not so clear, because a tiny little dose of that medicine may not have a huge impact on how much it's going to improve your Raynaud's. So. Plaquenil, the question was about Plaquenil. Plaquenil is what we think an immune kind of modulating drug. It's helpful to treat skin and joint problems, not skin and scleroderma so much as skin and lupus and other things. So it gets used for a number of other things amongst the connective tissue diseases, but probably doesn't have any benefit in terms of Raynaud's. But joint problems is the thing that we probably use it the most for. Sure. So I'm going to stick around for a few more minutes if people have questions, but otherwise I want to give you guys time to go to your next session.